From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
Hello, and welcome to our listeners around the world. You're listening to JAMA Neurology Author Interviews. Thanks for joining us. I'm Dr. Cynthia Armand, Associate Professor of Neurology at Albert Einstein College of Medicine, Montefiore Medical Center, and JAMA Neurology Web Editor. Today, we are discussing Huntington's disease, specifically talking about treatment. I have with me Dr. Jordan Schultz. Dr. Schultz is an Assistant Professor of Neurology and Psychiatry at the Carver College of Medicine at the University of Iowa. Dr. Schultz, welcome to the podcast and thanks for joining us.
Thanks so much for having me, Dr. Armand.
Huntington's disease. So we know this is a progressive neurodegenerative disease that is marked by motor decline, cognitive decline, and psychiatric decline. The treatment landscape of this disease, what do we look at now? What's out there currently? And tell me about the rationale behind your current work entitled Beta Blocker Use and Delayed Onset and Progression of Huntington's Disease.
There is a lot that we know about Huntington's disease, and there's a lot that we still do not know. We have learned a lot about the pathology of the disease, but at the same time, the Huntington protein, and specifically the mutant Huntington protein, we really don't know exactly what that does. And so the general treatment landscape over the past decade or so has been really focused on therapeutic candidates aimed at lowering mutant Huntington protein. Unfortunately, the HD community has received some negative news about that strategy, but it's still a very promising strategy that is being developed by several different groups. How our work fits into that is based on an observation that we have made previously, which is that there are signs of autonomic imbalance in patients with Huntington's disease. And specifically, patients with HD seem to have lower parasympathetic tone and an increase in sympathetic tone. And interestingly, those symptoms seem to be correlated with disease burden and disease progression. So the thought that we had based on those observations was, if you give a medication that can block norepinephrine, the primary neurotransmitter of the sympathetic nervous system, could you potentially slow the progression of this disease or at least dampen the symptoms somewhat? So that was the basis for our study. And hopefully it fits into the therapeutic landscape by generating new hypotheses about a novel pathological mechanism.
In clinical practice, are individuals currently using beta blockers for certain symptoms of Huntington's disease? I know in neurology, we think about essential tremor, anxiety, using beta blockers for those, especially because of that sympathetic tone association.
So the majority of patients that are using a beta blocker concomitantly with a diagnosis of HD are generally using it for a cardiovascular comorbidity.
Okay.
However, it certainly is a treatment option for exactly some of those symptoms that you described. It might not be first line, but it really depends on what else the patient is taking, other comorbidities. So it can be used, but it would be relatively new to say you should treat symptoms of HD with a beta blocker.
Take us through the methods of this work that you've done with your colleagues.
Sure. So this work is made possible by leveraging the Enroll HD platform. So this is a very large observational study. It's a worldwide study sponsored by the CHDI Foundation, and tens of thousands of participants have been in that study and continue to be in that study. And so we have a large pool of patients with HD at various stages of the disease, as well as control participants. And so we really wanted to look at how beta blockers affect patients with HD at different stages of the disease. And so we first looked at patients who were in the pre-manifest phase of the disease, so before they have received a motor diagnosis. And we tried to get patients who were relatively early on in that stage of the disease. Once we identified those subjects, we identified the patients who were using a beta blocker for at least a year prior to receiving a motor diagnosis, if they did during that time point. And then most importantly, because of the size of the Enroll HD study, we are able to perform propensity score matching based on several clinical characteristics, including age, CAG, cognitive scores, et cetera. So that gave us a cohort of treated or untreated in the pre-manifest phase. And then we did the same thing in patients who had already received a motor diagnosis or motor manifest HD patients. So we identified all those patients, then identified those who were taking a beta blocker, and were able to match those patients to people who had never taken a beta blocker. And that really helped us to eliminate, as well as we could, obviously we can't eliminate everything, but eliminate a lot of the potential confounders with this. So in the pre-manifest patients, we performed a survival analysis to see if the annualized risk of receiving a motor diagnosis was different between the treated and untreated groups. And then in the motor manifest group, we evaluated the rate of change of their motor score, the cognitive score, and their functional scores between the treated and untreated subjects.
Okay. We're not talking about juvenile onset Huntington's disease, correct?
Correct. We specifically excluded participants who may be more likely to have juvenile onset HD. So we did that based on the number of CAG repeats. So we only included patients with CAG repeats less than 55. Mm-hmm. And we excluded participants who had received a motor diagnosis prior to the age of 21, which is oftentimes used to define juvenile onset HD. And the real reason for that is because juvenile HD, while it represents a lot of similarities to adult onset HD, it is a very fast and aggressive form of the disease. And so those participants were excluded to remove that potential confounder.
Right. Now, beta blockers, I know that of the varieties that are available, they have different properties in how they function. Were you looking at specific types of beta blockers and comparing against one versus another?
For the primary analyses, we were grouping all beta blockers together. That is a challenge, and that is the basis for some of the post hoc analyses that we performed. Mm-hmm. So beta blockers can come in you can split them up in a variety of different ways. You can have beta 1 selective medications. Mm-hmm. There are lipophilic versus hydrophilic beta blockers. And so we looked at all of them for the primary analyses, but our first post hoc analyses split up the beta 1 selective medications versus the non-selective, so those that hit the beta 1 and beta 2 receptor.
Many times patients are on different types of blood pressure medications. Were there any others that were noted that affect sympathetic tone? Like, for example, angiotensin converting enzyme inhibitors. Were those looked at as well, just in case if patients were also on a medication of that sort?
So first, we included whether or not someone had a concomitant diagnosis of hypertension mm-hmm. in our matching procedures, as well as diabetes and other cardiovascular comorbidities, use of a statin or not. So that was part of the propensity score matching. As a post hoc analysis, we wanted to look at patients who were using an ACE inhibitor or an ARB, an angiotensin receptor blocker, and perform the same analyses that we did with beta blockers, but in that other class of medications that is used for hypertension primarily. And the rationale for that was exactly what you were saying. Both ACE inhibitors and angiotensin receptor blockers can impact sympathetic tone, but they do it in a different manner than beta blockers. Beta blockers work at the beta receptor to block the action of norepinephrine, whereas ACE inhibitors and ARBs have the potential to decrease the release of norepinephrine before it hits that receptor. And so we investigated those as well to determine, is another medication that is working on the cardiovascular system going to exert the same effect or not?
Mm-hmm. All right. Well, tell us about what you found.
So we found that in both the pre-manifest HD subjects that were treated with beta blockers and the motor manifest subjects who were treated with beta blockers, there were positive clinical results associated with the use of beta blockers versus non-users of beta blockers. So the pre-HD subjects demonstrated a significantly lower annualized risk of receiving a motor diagnosis relative to the subjects who are not taking a beta blocker. Mm-hmm. And then in that separate cohort of motor manifest subjects, the annualized rate of progression of both the total motor score, the total functional capacity score, and the symbol digit modalities test, the rate of worsening was decreased in the patients who were taking a beta blocker compared to those who were not.
Oh, wow. And my next question is about the different types of beta blockers. Was there anything there that was significant in terms of which types we can potentially use versus another?
So one, Huntington's disease is a neurological disease. So we were interested initially in whether or not there was a difference between lipophilic medications, which would be more likely to cross the blood-brain barrier and reach the brain, versus hydrophilic medications. Unfortunately, more than 90% of the subjects taking a beta blocker were taking lipophilic medications. So we were unable to compare hydrophilic to lipophilic. But we did look at the selective versus non-selective beta blockers as a post-hoc analysis. Mm-hmm. And both the selective and non-selective beta blocker user groups showed the same clinical improvements from the primary analysis, but there was no difference between selective and non-selective. So they both demonstrated improvement compared to non-users, but not necessarily compared to one another.
Mm-hmm. Okay. So yeah, I was interested in that because of the variety of options that we have. The question is always, well, which one do we choose?
Right.
Especially from test results like this.
Yeah. And another interesting finding was when we performed another post hoc analysis looking at the impact of beta blockers on anxiety and other psychiatric symptoms in the patients with Huntington's disease. And the reason that we were interested in this is that there are previous data to suggest that a reduction in anxiety and other psychiatric symptoms can actually improve some of the motor and functional symptoms as well as quality of life. So the question we were trying to answer is, are the benefits that we're seeing from beta blockers kind of a secondary effect of their known impact on psychiatric symptoms? And interestingly, the change in anxiety scores in both the pre-HD and motor manifest HD was not different between the beta blocker users and non-users.
Okay.
In the motor manifest subjects, we were able to look at those symptoms longitudinally between the users and non-users. And again, there was no difference between the groups. And we thought there's probably some people who actually have a large decrease in anxiety and others who do not. Mm-hmm. So we took the slope of change of their clinical symptoms, the motor, functional, cognitive symptoms, and we also took the slope of change of each individual's anxiety scores over the time frame that we evaluated them and correlated those. And there was no correlation between how anxiety scores changed and how their other clinical symptoms changed. It's still possible that the beta blockers are positively impacting the motor and cognitive symptoms via their effect on the psychiatric symptoms, but our results were not supportive of that idea, suggesting another potential mechanism.
Very interesting finding that you had there. Now, what do we take from this for the future? I certainly take hope. I take that there are possibly added pharmacologic entities that can be helpful in terms of maybe slowing down disease progression. But obviously, this is preliminary. So what are we looking at in terms of follow-up and transitioning to clinically interpreting this study?
You are very much correct that these are early findings. We're very much, early on in the journey with beta blockers and HD. So before we would feel comfortable recommending these to patients, we would need randomized controlled trials with different outcomes, things like that. So while these results are very exciting, there's still a lot of work to be done to determine whether or not these could be used as a potential treatment for patients with HD. I think you're exactly right in that the part that I am most excited about and most hopeful about is that these results provide some level of information that maybe we can modify the disease course. Maybe there are novel therapeutic targets that we can investigate further, that maybe beta blockers showed a pretty good effect here. But if we investigate those pathological mechanisms, we may be able to identify better medications that would be a better therapeutic candidate for the next randomized controlled trial. So I think that these results open the door for new investigative directions in HD that could potentially lead to new trials for disease-modifying therapies.
Dr. Schultz, thank you so much to you and your colleagues for this work and talking to our listeners about this.
Thank you so much for having me, Dr. Armand. I really want to thank my colleagues. I especially want to thank all of the patients and participants who are a part of the Enroll HD study, who are participating in research, and who are just living their lives every day. And I also want to thank the CHDI Foundation for their work on the Enroll HD platform, making it available to researchers so that we can move science like this forward.
I'm Dr. Cynthia Armand, and I've been speaking with Dr. Jordan Schultz about treatment for Huntington's disease, mainly beta blocker therapy. You can find the link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.